Today we're going to discuss shock, a critical condition characterized by decreased tissue perfusion regardless of its cause. In this session, we'll lay out the foundation for understanding shock, exploring the stages patients may be experiencing, and subsequently we'll delve into specific types of shock and the treatments for each in class. So, what exactly are these types of shock? Septic shock arises from severe infections. Hypovolemic shock occurs due to significant fluid loss. Cardiogenic shock is often a result of a weakened heart, unable to pump effectively, commonly triggered by an acute myocardial infarction. Then there's anaphylactic shock, and that stems from allergic reactions. Neurogenic shock can happen with severe damage to the nervous system, such as a spinal cord injury, or obstructive shock, and that's due to impediments to blood flow, like cardiac tamponade. So, no matter the type, the outcome is the same: poor organ perfusion, leading to cellular hypoxia. As we discuss the stages of shock, we'll see how the body attempts to compensate, shifting to different metabolic processes to save cell function. If uncorrected, this cascade can lead to multiple organ dysfunction syndrome, or MODS, where organs shut down, potentially resulting in death. That's why recognizing and treating shock aggressively is vital. The stages of shock are sequential. The initial stage, the compensatory stage, which is reversible, the progressive stage, and finally the refractory stage, which is irreversible and often leads to MODS and death. In the initial stage, pay close attention to the cellular response to hypoxia. Cells switch from aerobic to anaerobic metabolism, leading to lactic acid production, which, if unchecked, can cause significant problems, including lactic acidosis. Consider a hypovolemic shock scenario. A massive loss of fluid diminishes cardiac output, the amount of blood the heart pumps per minute. As a result, tissue perfusion drops and cells switch to anaerobic metabolism. However, this leads to lactic acid buildup since organs like the liver, also suffering from low perfusion, cannot process it efficiently. In the compensatory stage, the body employs the neural and hormonal responses to counter the effects of anaerobic metabolism, aiming to improve blood pressure and oxygen delivery to the cells. It's a critical window for intervention. If we successfully address the underlying shock, the patient can recover. Otherwise, they advance to the progressive stage. In the progressive stage, compensatory mechanisms fail, and we witness the consequences. Vital organs begin to falter, heralding the approach of MODS. The body struggles to maintain cardiac output, and widespread cellular death ensues, accompanied by systemic issues like increased capillary permeability. Lastly, the refractory stage represents the point of no return, where organ systems shut down and recovery becomes impossible. As we dissect these stages, we'll discuss the subtle initial signs and symptoms, how our organs, especially the kidneys, attempt to adapt, and the overall impact on bodily functions. Our focus will be on how to identify and intervene effectively to prevent progression to the final and most dire stage. The journey through shock unfolds in stages. Initially, the compensatory stage, which is potentially reversible, then, if uncorrected, it progresses to the more severe stages, culminating in the refractory stage, synonymous with irreversibility and often leading to death. In the initial stage of shock, observe the cellular response to oxygen scarcity. Cells deprived of adequate perfusion are forced to switch from efficient aerobic metabolism to less efficient anaerobic metabolism, producing lactic acid. This shift is a pivotal moment in the cascade of shock. Imagine a patient in hypovolemic shock. They've suffered a massive fluid loss. The heart, now deprived of sufficient blood volume, struggles to maintain output, which is crucial for delivering oxygenated blood to tissues. This reduction in cardiac output is the starting point for tissue hypoperfusion and cellular distress. In response to this initial stage, the body employs its sophisticated compensatory mechanism, harnessing neural and hormonal pathways to fight off the harmful effects of decreased perfusion. If we can intervene successfully during the compensatory stage, the patient has a chance for full recovery. If we fail, the patient slips into the more progressive stage. This is where the body's compensatory efforts begin to falter, signaling the onset of a downward spiral that can lead to MODS. The heart is no longer able to keep up, and vital organs begin to suffer from oxygen deprivation. Here, the patient's condition visibly worsens, marking a critical juncture for the medical intervention. In the progressive stage, we witness the collapse of compensatory measures, and the patient moves inexorably towards the final stage, the refractory stage. Here, the shock has become unmanageable. Despite all efforts, organ systems shut down one by one as the patient nears the end of life. Throughout these stages, we'll learn to recognize subtle changes in patient condition, understand how the kidneys and other organ systems attempt to adapt, and see the broader impact of the body's functioning. It is a journey from the first cellular changes in the metabolism to the systemic failure that characterizes the most advanced stages of shock. Let's focus on this illustration, which details the cellular and biochemical events when there is impaired oxygen use. This is a state where cells cannot effectively use oxygen, leading to a series of detrimental events at the cellular level, shown here as a cascade. When cells are deprived of oxygen, they cannot produce ATP, the energy currency of the cell, efficiently. Without ATP, critical functions like the sodium-potassium pump fail to work properly. The sodium-potassium pump is responsible for maintaining the balance of sodium and potassium ions inside and outside the cell. As it malfunctions, sodium accumulates inside the cell and potassium leaks out, causing water to follow sodium into the cell, which leads to cellular edema. This swelling can cause the cell membrane to disrupt, leading to the release of lysozymes, which are like little demolition experts in the cell. They contain enzymes that break down cellular components, but if they're released indiscriminately, they can damage the cell itself. This disruption contributes to what we see at the bottom of the spiral, continuous positive feedback loops. This means that the damage causes more damage in a vicious cycle. Moving to the right side of the diagram, we see a lysosome depicted and arrows pointing to the effects of their breakdown products, such as decreased glutathione volume, which is important for cellular defense against oxidative damage. This breakdown leads to an increase in lactic acid, a byproduct of anaerobic metabolism, which occurs when cells don't have enough oxygen to produce energy efficiently. Lactic acid buildup decreases the blood's pH and can impair other cells' oxygen use even further. The green block points to decreased cell fixation, repair, and division, vital processes for cell survival and regeneration. The olive block indicates inflammation, which is a protective response to injury or destruction, but can be harmful if unchecked. Lastly, the gold block shows activation of coagulation cascade, which can lead to blood clots and further decrease blood supply to tissues. Now, imagine all of these processes happening throughout the body. It's easy to see why impaired oxygen use can lead to serious complications. Our body relies on a constant supply of oxygen, and when that supply is compromised, it's like a row of dominoes falling. Do we understand how a local event at the cellular level can have far-reaching effects on the whole organism? Turning our attention to this slide, we're examining the domino effect of impaired glucose use due to shock on the body's physiology, particularly in a severe scenario where recovery becomes unlikely. First, on the left, we see that cell function and membrane integrity are compromised. The image highlights the heart and lungs, organs particularly vulnerable to changes in cell and membrane health. The decrease in membrane integrity leads to osmotic pressure changes, which in turn causes interstitial edema, an accumulation of fluid in the spaces around the cells, disrupting normal cell function and exchange of substances. This initial damage spirals into a cycle of worsening conditions. The body responds to the stress by increasing the levels of cortisol, thyroid hormones T3 and T4, and catecholamines, which are indicated by the green spiral. These hormones are attempting to maintain blood pressure and supply oxygen and nutrients by increasing heart rate and vascular resistance. However, this response has a high metabolic cost and can lead to an increased demand for oxygen and energy substrates at a time when the body is least capable of supplying them. On the right, we see the outcomes of this increased metabolic demand during shock. In the case of septic shock, characterized by infection and systemic inflammation, there's a high metabolic demand accompanied by fever. The body may also develop insulin resistance, a state where it fails to use insulin efficiently, leading to increased levels of blood glucose, which further taxes the body's already strained resources. The text points out that this can lead to increased heart rate, systemic vascular resistance, and cardiac contractility, placing even more strain on the heart. Additionally, as a byproduct of increased metabolism, there's an accumulation of ammonia, urea, and a change in immunoglobulin metabolism during sepsis. These metabolic alterations are both a consequence and a cause of further deterioration. Finally, we see the stark statement, shock likely irreversible, indicating that the window for effective intervention may have closed. This stage is often marked by the depletion of compensatory mechanisms and the onset of multiple organ failure. This diagram illustrates how the failure to utilize glucose effectively during shock can precipitate a vicious cycle of stress responses and metabolic crises that culminate in irreversible organ damage. The progression from cellular dysfunction to systemic failure underscores the urgency of treating shock promptly and effectively. Now, let's unpack the complexities of positive feedback loops that occur during shock, which are well summarized in this positive feedback loop recap diagram. These loops, unlike negative feedback loops that stabilize the body, exacerbate conditions and drive the body further into shock. On the left side, we see serum albumin plasma proteins used for fuel. Normally, serum albumin and other plasma proteins maintain oncotic pressure, which is the pool of water into the bloodstream. However, during shock, the body may break down these proteins for energy, leading to several problems. It decreases capillary oncotic pressure, which reduces the ability of blood vessels to draw fluid back from tissues, resulting in interstitial edema, swelling in the spaces around the cells. And then we can have decreased circulatory volume, as fluid accumulates in the interstitial spaces instead of staying in the circulatory system. We can also have impaired glucose delivery because the fluid that normally carries glucose is now trapped in tissues. And lastly, a need for gluconeogenesis, where the body starts to make glucose from non-carbohydrate sources, further putting strain on the metabolism. Moving to the right side, we delve into septic anaerobic metabolism. Here, the cells resort to anaerobic protein metabolism, leading to production of lactic acid and a decrease in pH. This results in worsening metabolic acidosis, and degrades glucose metabolism, making the body's energy crisis even worse. At the bottom, we find depletion of protein used for fuel. This leads to toxic levels of ammonia and urea, which are harmful byproducts of protein breakdown. It causes impaired cellular structure, function, repair, replication, and further exacerbating tissue damage. And critically, it impairs respiratory and cardiac function, which is essential systems for survival. The result is delivery of oxygen glucose is impaired, denying cells the substances the most need to survive and recover. In essence, this diagram illustrates a dire situation where the body's response to stress ends up causing more stress, creating a loop that can be challenging to break. Now, let's recap on the effects of inadequate oxygen delivery at the cellular level and how this can lead to a state known as anaerobic metabolism. Please direct your attention to the diagram on the screen, which is divided into two sections, detailing the consequences of ATP depletion and the effects of anaerobic metabolism on the body's pH. Starting with the left panel, titled Depletion of ATP in Anaerobic Metabolism, we dive into the cascade of events triggered by insufficient oxygen. The sodium-potassium pump, a vital cellular mechanism for maintaining electrolyte balance, becomes dysfunctional. This dysfunction is significant as it can lead to nervous system and heart muscle damage due to the essential roles of sodium and potassium in these tissues. Continuing down the list, we encounter cellular edema. This swelling of cells occurs as a direct consequence of the sodium-potassium pump failure, leading to a decrease in circulatory volume and an increase in the presence within the tissues. Additionally, the integrity of cell membranes is compromised, resulting in lysosomal release and subsequent cell destruction. Lastly, in the left panel, we discuss the inflammation clotting cascade. This systemic response not only contributes to the development of multiple organ dysfunction syndrome, or MODS, but also exacerbates the already impaired oxygen use by the cells. Transitioning to the right panel, anaerobic metabolism decreases pH. We see how cells adapt to a lack of oxygen by utilizing lactic acid as a fuel source, which lowers the pH, contributing to an acidic environment that disrupts cellular enzymes responsible for key functions like repair and division. This shift towards acidity, known as metabolic acidosis, has a detrimental effect on the oxygen carrying capacity of blood, further compounding the problem. The list of the panel echoes the left, indicating a destructive loop between lysosomal destruction, inflammation, clotting, and the worsening of MODS, all linked back to anaerobic metabolism and the resultant decrease in pH. This diagram succinctly illustrates a complex interplay of factors that arise from a lack of oxygen at the cellular level, which can quickly spiral into a life-threatening systemic issue. It's important for us to understand these mechanisms as they are the foundation for many critical care interventions we apply in clinical practice. Let's shift our focus to this diagram, which outlines some of the typical complications of shock. When the body experiences shock, it's not just the immediate symptoms we're concerned about, but also the potential for serious complications that can develop. At the heart of these complications is the inflammatory response, illustrated by the central green box. This response is the body's natural defense mechanism to injury or infection, but when it's excessive or uncontrolled, it can lead to a variety of issues. The inflammatory response can cause acute tubular necrosis, shown here in the purple box. This condition affects the kidneys and is a common cause of kidney failure. It occurs when the tubular cells that make up the kidneys become damaged and die, which is often a result of the decreased blood flow and oxygen that accompanies shock. Moving to the brown box labeled DIC, which stands for disseminated intravascular coagulation, we see another severe complication. DIC is a complex condition that involves both excessive bleeding and clotting. It happens because the inflammatory response triggers widespread clotting in small blood vessels, and this, paradoxically, can lead to a depletion of platelets and clotting factors, causing bleeding. Finally, in the red box, we see ARDS, which stands for Acute Respiratory Distress Syndrome. ARDS is a type of respiratory failure characterized by rapid onset of widespread inflammation in the lungs, again stemming from the initial inflammatory response. Notice that inflammation and clotting cascade are listed to the right of the diagram. These are the drivers behind the scenes, exacerbating the inflammatory response and leading to the complications we see listed. Understanding these potential complications emphasizes the importance of treating shock early and aggressively. Each of these conditions can further complicate the clinical picture and, unfortunately, can be fatal if not managed properly. As we examine this flowchart, we'll see how decreased tissue perfusion can lead to a multifaceted problem within the body. This is crucial to understand as it underpins many conditions we have already studied in this course. The chart starts with decreased tissue perfusion at the top left, which means that the blood flow to the tissues is reduced. This can be due to several reasons, such as shock or heart failure. Reduced perfusion leads to inadequate oxygen and glucose delivery, which are both essential for cellular metabolism. When cells can't get enough oxygen or glucose, we see impaired cellular metabolism, which has two main consequences: impaired oxygen use and impaired glucose use. On the left, impaired oxygen use results in anaerobic metabolism, where the cells start to produce energy without oxygen. This leads to an increase in lactase, causing metabolic acidosis, an acid-base imbalance that occurs when the body has too much acid due to the anaerobic metabolism. As a result, ATP production drops. The sodium-potassium pump fails, and cellular edema ensues as the cells take on water. This cellular edema contributes to a further decrease in intravascular volume, the volume of blood within the blood vessels, which can cause tissue damage and dysfunction, and initiate inflammation and clotting, leading to potential complications like blood clots. On the right side of the flowchart, impaired glucose use is shown to lead to increased serum glucose. The body's response to stress involves the release of catecholamines, cortisol, and growth hormone, which raise blood sugar levels more so. However, this can also trigger lipolysis, glucogenesis, and glycogenolysis, processes that break down fats and glycogen into glucose, further increasing blood glucose levels. This hyperglycemic state causes serum albumin and muscle wasting, as the body uses proteins for energy, which then leads to an accumulation of ammonia and urea, byproducts of protein metabolism, and those can be toxic when at high levels. And ultimately, this leads to a depletion of energy stores. To sum it up, this chart shows us how a single issue like decreased tissue perfusion can spiral into multiple complex problems, affecting everything from cellular metabolism to whole body energy stores. It highlights the importance of early intervention to prevent this cascade of complications. Let's turn our attention to this vital topic, the treatment objectives for managing a patient in shock. Our goal is to recognize the problem early, identify the cause, and intervene to prevent progression and organ damage. The left side of the diagram outlines the signs and symptoms of shock, while the right side focuses on the treatment strategies. First, we have to be able to recognize non-specific signs and symptoms of shock, which often present subtly. Alterations in the level of consciousness can indicate that the brain isn't receiving enough blood flow. Decreased CO refers to cardiac output, which, if reduced, affects the entire body. We look for cold, clammy skin, shortness of breath with increased respiratory rate, possibly leading to respiratory alkalosis due to the overbreathing, decreased urine output, and, of course, hypotension. We may also see an increased heart rate, although this isn't mentioned explicitly. On the right, we have the core treatment goals. Discover and correct the cause. And this is our starting point. Identifying the underlying issue is critical for targeting therapy. Then we work to expand intravascular volume to combat the decreased preload seen in shock. We need to counteract the vasodilation, which that's essential. Vasodilation can be a compensatory mechanism, but it may lead to further drops in blood pressure. And we use the MAP, or mean arterial pressure, as a guide to determine the adequacy of tissue perfusion. The equation for MAP is given as the sum of twice the diastolic plus the systolic pressure divided by 3. We aim for a MAP of at least 60 to 65 to ensure enough blood flow to the organs. Supplemental oxygen may be needed to improve tissue oxygenation, and in some cases, positive pressure ventilation is required. Glucose control is also crucial because hyperglycemia can worsen outcomes in critical illnesses. Lastly, a cautionary note. Once positive feedback loops are in progress, they are difficult to manage. This reiterates the importance of early recognition and treatment to prevent the establishment of these deleterious loops. In front of us is a chart detailing the actions of adrenergic receptors. These receptors are part of our sympathetic nervous system, the system that governs our flight or fight response. The adrenergic receptors are divided into two main types, alpha and beta, and each has subtypes with different functions. Starting with the alpha receptors. Alpha-1 receptors, when stimulated, lead to vasoconstriction, which increases blood pressure. This subtype also triggers glycogenolysis and the breakdown of glycogen into glucose, providing energy for the body during stress. Additionally, it causes mydriasis, which is the dilation of the pupils. Alpha-2 receptors are a bit different. They act to block sympathetic activity when stimulated, helping to modulate and prevent overstimulation of the nervous system. Now, let's look at the beta receptors. Beta 1 receptors are primarily found in the heart. Their stimulation increases heart contractility and heart rate, which we denote as HR. They also lead to an increase in renin release, which is part of the body's way of raising blood pressure. Beta 2 receptors are found in the lungs and vasculature of the skeletal muscles. Stimulating these receptors leads to dilation of the bronchioles, making breathing easier. They also promote glycogenolysis, similar to alpha 1 receptors, but in a different context. Off to the side, we see a note about decreased gastric motility. That's a common side effect of sympathetic activation. When the body is preparing for a quick response, digestion is not a priority. These receptors are targets for various medications, which can either stimulate or block these effects. For instance, beta blockers are used to manage high blood pressure by inhibiting these receptors. This diagram is a great reference for understanding the sympathetic nervous system's role in different body functions and the pharmacological actions we can take to influence them. Let's look at this slide, which provides a clear depiction of the considerations when using vasoactive adrenergics, a class of drugs that are critical in managing patients with shock. At the center of our diagram is vasoactive adrenergics, which are medications that mimic the sympathetic nervous system, or SNS. They work by activating adrenergic receptors, which are catecholamines like adrenaline and noradrenaline. These drugs are potent with a rapid onset of action. The yellow node connected to our central drug class is potent, rapid onset, highlighting the immediate effect these drugs can have on the cardiovascular system. It's because these powerful effects that we must also consider the max dose, as represented by the dark pink node, which is the highest amount of the drug that can be safely administered to achieve the desired therapeutic effect. Moving to titrate hemodynamic stability, the light pink node. We see the importance of carefully adjusting the drug dosage to maintain stable blood pressure and heart function. Wean, connected to this node, refers to the gradual reduction of the dosage, which is vital to avoid rebound effects on blood pressure and heart rate. Below our central drug class, we find rapid half-life, depicted in the green node. This indicates that these drugs do not stay in the body for long, which is beneficial in acutely managing hemodynamics because their effects can be quickly reversed if necessary. Now, let's look at the blue node, ECG monitoring. And this is crucial because these drugs can cause significant changes in heart rate and rhythm, necessitating continuous electrocardiogram monitoring. On the other hand, non-selective agonists refer to the specificity of the drug. Some affect only certain types of adrenergic receptors, while others have a broader effect. Finally, the purple node at the bottom, extravasation, warns of the potential complication where the drug may leak out of the blood vessel into the surrounding tissue, causing local damage. It's a risk associated with intravenous administration, especially of potent vasoactive medications. This slide synthesizes the key aspects of using vasoactive adrenergic drugs. They're powerful, require careful monitoring and dosing, and must be managed to avoid local and systemic complications. Let's look at our last slide. And this is an engaging diagram which will help us remember the different effects on the heart using visual association. On the left, we have an inotropic effect. Inotropic is the force, hence the child, Grogu. This is the force of contraction. In the middle, there's chronotropic, depicted by a clock. It's easy to remember that chronotropic factors change the heart rate. The chrono part of the word reminds us of time or clock. On the right, we have dromotropic, indicated by an image of electrical impulses. These impulses remind us of the conduction speed of electrical signals in the heart, much like the fast movement of electricity. Remember, these terms are used to describe the action of drugs or the body's own physiological responses on the heart's function. Inotropes affect contraction strength. The chronotropes affect the rate and the dromotropes affect the conduction velocity. So when we talk about the medication having positive inotropic effects, we mean it increases the force of the heart's contraction. A negative chronotropic drug would slow down the heart's rate, and a positive dromotropic agent would speed up the conduction of electrical signals in the heart. With these visual aids, I hope you'll find it easier to recall these terms. Can you think of any examples of drugs or situations where these effects would be significant? This concludes our pre-lecture video where we discuss the pathophysiology of shock. In class, we will go over the different types of shock and their subsequent treatments.